Hi everyone, my name is Marie McGrogan and I'm the Clinical Advisor for TG Aiken. On behalf of Aiken, I would like to welcome you all and say a huge thank you for joining us today. We really do appreciate it, particularly during such challenging times. I recently produced a white paper focusing on the psychological impact of stoma-forming surgery. And during the research and development, it became quite evident that whilst there has been huge progression within the quality and efficacy of both products and services, it was also abundantly clear that the psychological impact of stoma formation continues to be a considerable issue for many patients. The studies consistently highlighted three main areas of concern. Firstly, the loss of control leading to a grieving process, then the altered body image with reduced self-esteem, and the importance and value of self-efficacy for our patients. And then the fear of intimacy resulting in psychosexual issues for many patients. And finally, as enhanced recovery is now embedded into clinical practice in many countries, stoma care nurses are under increasing pressure to prepare patients for earlier discharges, therefore reduce time spent on psychological support. Over the past decade, there's been a growing realisation that successful surgery is not dependent solely on the operation alone, but rather on how well the patient is able to return to a physically and psychologically healthy state. Enhanced recovery after surgery has been associated with a risk reduction in postoperative complications, shorter hospital stays, and no increase in readmission rates. There is also growing evidence supporting the introduction of prehabilitation, whereby interventions such as exercise, nutrition, and anxiety reduction in the preoperative period can complement the enhanced recovery programme and facilitate the return to baseline activities of daily living. So with this in mind, we are now embarking on our second webinar, which will explore how enhanced recovery after surgery improves patients' outcomes with this evidence-based pathway, but also provides a patient-centred approach, ensuring that patients feel supported throughout their surgical journey. So without further ado, I would like to introduce you to today's expert speaker, Deirdre Cunningham. Deirdre is an enhanced recovery nurse for the colorectal service in Belfast, Northern Ireland. She has 20 years experience in colorectal surgery, both within the NHS and in the independent sector in various roles: staff nurse, pre-assessment nurse, ward manager of colorectal surgical wards, and most recently setting up a formal colorectal enhanced recovery service within her hospital. Deirdre's presentation today is entitled Enhanced Recovery After Surgery, Improving Patient Experience and Surgical Outcomes. At the end of Deirdre's presentation, we will then move into a 15-minute Q&A session. So please feel free to enter any questions in the chat box throughout the presentation, and we will endeavour to answer when Deirdre has completed her presentation. On behalf of Aiken, I would like to say a massive thank you to you, Deirdre, for agreeing to present and share your wealth of experience today. Over to you, Deirdre.
Good afternoon. My name is Deirdre Cunningham and I'm a colorectal enhanced recovery nurse. I'm based in Belfast, Northern Ireland, and today I'm going to talk to you about enhanced recovery after surgery, improving patient experience and surgical outcomes. Enhanced recovery after surgery, or ERAS, is a patient-centred, evidence-based, multidisciplinary pathway and unit culture which aims to reduce patients' surgical stress response, optimise physiologic function and facilitate recovery. In other words, it helps patients get better quicker after major surgery. And good compliance to an ERAS pathway improves short and long-term outcomes. So I'll explain a little bit about the role of the enhanced recovery nurse in my service. And of course, it's important to say that it's not going to be the same in every service or hospital. That needs to suit your own service and suit the needs of the service and the patients. So preoperative information giving to patients about their expected goals and discharge dates. And it's really important at this stage that patients are encouraged to take responsibility for their own recovery. But they also need to know why they're doing the interventions that we're encouraging them to do. So it's important to present the evidence to patients at this stage. We see patients daily while they're in hospital, and we encourage their daily goals towards discharge. We use a patient diary if it's appropriate, if the patient's going to respond to that and if it's going to be helpful for the patient. We provide telephone follow-up post-discharge. Patients are phoned twice after discharge, and they can phone the ERAS team at any time. And this isn't prescriptive. If patients need more support, we can give them extra phone calls. We collect data and enter that into our ERAS dashboard. Teach and support all staff across staff areas, and exploring barriers to implementation, of which there are, I would imagine, in every service. Regular strategy meetings of the core team and updates to the larger team. We feedback data regarding, for example, compliance and length of stay. We liaise with our ERAS colleagues in the UK to benchmark our service and ensure that the latest evidence is incorporated into our practice, and provide strategic influence locally and regionally. So I'm going to go into a wee bit more detail of the interventions that we do in each area, starting with pre-operative interventions. So information giving to patients, as mentioned earlier, is really, really important. The multidisciplinary team needs to really be giving the same information to the patients to manage expectations. It's not helpful to the patients or their recovery for people to be saying different things, even slight differences. So we need to make sure that that's consistent throughout the team. Stoma nurses see our patients face-to-face pre-operatively in our hospital. They provide pre-operative counselling and practice packs. I think it's important at this stage that patients are really encouraged to use their practice packs. We do notice the difference between patients who have, and I'm sure you do as well, patients who have actually used their practice packs at home. They seem to be more confident, they learn quicker while they're in hospital, and they get out a wee bit quicker. Pre-assessment and anaesthetic assessment if appropriate, and a surgery school if that's provided in your service or hospital. It's also important to give written information at this stage. We all know that patients who are seen in an outpatient setting, and probably our own experience as well, it's really difficult to remember everything that they have been told in one attendance. And in our hospital, the patients see the surgeon, they see the pre-assessment nurse, they see the stoma nurse, and they see the health recovery nurse on the same day. So written information about their operation and also about post-operative expectations is really important to give patients at this stage. We need to be optimising their medical status. So patients who have iron deficiency anemia should be referred to an IV iron service. Or if there's time to optimise them with oral iron before their surgery, then to use oral iron. We need to improve patients' diabetes if they have diabetes, stop smoking as well, and reduce and stop alcohol safely at this stage. Prehabilitation is an ideal for lots of hospitals. Some hospitals have the facilities to have a prehab service. And I think that would probably be the ideal for most places if resources existed. So a facility where the patients could have a bespoke exercise program before their surgery, if it was appropriate. Obviously with colorectal surgery, with our cancers, we have a very short window of opportunity to improve patients' activity levels in order to improve their post-op outcomes. But for example, our patients who need long course chemoradiotherapy before surgery, they would be the ideal patients to use prehab with. We use carbohydrate drinks for most of our patients. This helps to reduce metabolic stress and improve outcomes post-op. And of course, we don't use these for diabetic patients or patients with a known gastric emptying disorder. the evidence isn't there just yet to use with these patients. Bowel preparation. The evidence is to minimise bowel preparation on its own. However, there's some evidence to suggest that bowel preparation used along with oral antibiotics can minimise anastomotic leak and surgical site infection. Not all hospitals are using this. We actually are, but we don't have enough data just at this stage to see whether it's actually having an effect. But systemic bowel preparation on its own, there is no evidence for its use. So ideally, it should be minimised. Not used at all. Intraoperatively. So balanced IV fluids are really important. The word balanced is kind of key there. We call it goal-directed fluid therapy. In other words, the patients get only the amount of IV fluids that they need. So we used to give patients far too much IV fluid, and that does not help post-operative recovery. In fact, it can be detrimental to post-op recovery. So in our service, the anaesthetists use waveform monitors so they can detect when a patient needs a bolus of IV fluid. We look at minimising the use of opiates. So, for example, for laparoscopic cases, patients get a single dose of intrathecal diamorphine. They have an IV lidocaine infusion, and we use non-steroidal anti-inflammatory medication unless it's contraindicated. And then post-operatively, obviously, we use very small doses of opiates, but we use the smallest dose that we can titrate easily, and obviously IV paracetamol, things like that. Laparoscopic technique, if possible, is ideal, and facilitates recovery, and minimising drains and tubes. This is I think always a slightly controversial area. For surgeons, it's still surgeon choice whether they use drains, particularly for low pelvic surgery, like abdominal perineal excision of rectum. Drains are still frequently used. The use of nasogastric tubes for elective surgery has not been in use for years, so I think in most services we wouldn't see that anymore. Temperature control is really important. We want our patients to be normothermic before and during, and obviously after their operation. This also improves their recovery. Post-operative nausea and vomiting prevention. In our own data, when we looked at it, we saw that a very high proportion of patients experience post-op nausea and vomiting. So that's a really easy thing to address with the use of several different antiemetics during the anaesthetic and post-operatively. And we use a regular regime post-op with rescue antiemetic on top of that if needed. Post-operative, what we want is the patient to return to normal as soon as possible, normal activities, and that includes eating and drinking. And we know that there's no evidence that fasting patients post-operatively now improves their outcomes. In fact, the quicker they can get back to eating and drinking normally, the better for the patient. So we encourage our patients to eat and drink normal diet. So no dietary exclusions, but in small portions after their operation. So really about 4 hours after surgery, they can start eating and they can drink as soon as they're awake and maintaining their own airway. Low residue diets really are only indicated, as the evidence says, for patients with new ileostomies or patients with multiple anastomoses, which wouldn't be the standard patient. We like to stop IV fluids as soon as possible. So as soon as the patient is maintaining their own fluid intake, we can stop their IV fluids, whether that's the night of the operation, if they've had their surgery earlier on in the day, or the next morning, or early the next morning. We like to stop them as soon as possible. multimodal opioid-sparing analgesia, again, as previously discussed. Opioids, as we know, can impact on post-op ileus, potentially. So we want to minimise the use of opioids after surgery. So we will use IV paracetamol for at least 24 hours. We'll use non-steroidal anti-inflammatory medication unless it's contraindicated. And we use IV lidocaine during surgery. Post-operatively, if there is a PACU or an HDU environment, then they can have their IV lidocaine infusion for a bit longer. If they're just going back to an ordinary surgical ward, then obviously that has to be stopped. And we use small doses of opioid, the ones with the most minimal side effect, in order to get a good result. In other words, the patient being able to get up and about and do their normal activities. Early mobilization is really important for patients in an enhanced recovery program, of course, all post-surgery. So ideally, we want them to get up and sit the evening of their operation. And obviously, this is one of the bigger challenges, I think, probably with enhanced recovery, with staffing levels the way they are, how the wards are resourced. So different services facilitate this differently. Whether they use nursing staff or extra physio staff, it can be different in every area. So up to sit the evening of surgery, a walk if possible. And obviously, the sooner we take out their tubes and connections, the easier it is for them to get back to normal activities. We encourage them to dress in normal clothes as well. Obviously, something comfortable, loungewear, but try and get out of pyjamas as early as possible and feel normal and feel well. We want patients to feel sick or think that they're not well. They're having surgery and we're going to get them better. Reiterate their estimated date of discharge at every opportunity that you have talking to the patient. In other words, so you're going to be going home in 3 days. This is what we need to achieve before you go home. And the expectations from the whole team. So we need every person in the team to be saying the same thing, as we've said before. It only takes one person saying, oh, you could be in for 2 weeks after this operation, and the patient then their focus will change completely. So we need to keep the patient focused and feeling responsible for their own recovery. Post-operative and post-discharge follow-up is really important for these patients. If we're looking at early discharges, day 2 or 3 after laparoscopic surgery, then they need to be supported at home. So they need to be signposted to who to phone if they have any issues, and we need to be contacting them and doing thorough assessments of how they're getting on at home and picking up any problems early. So we use the term dreaming in the UK. So drinking, eating and mobilising. We try and keep it simple for nursing teams, really post-operatively. So enhanced recovery can become very complicated if you make it complicated, or you can keep it simple for people. So are they drinking? Are they eating? Are they mobilising after surgery? So psychological support for stoma patients is obviously really, really important. We tend to become focused in hospitals on kind of a medical model, and it's easy to forget the psychological aspect. Although I think we do this instinctively as nursing teams. We know that we need to support our patients psychologically in order to support their recovery. So there's areas that we go into with psychological support, and this really starts as soon as the decision to treat information has been given to the patient from the surgeon. Face-to-face preoperative counselling from stoma nurses who give the patient literature. We ideally include relatives in counselling, although things are becoming a little bit more difficult in that area with COVID, but if close relatives is included in counselling, that can help support the patient as well. Their relative, their wife, their daughter, or whoever is going to be the one who will be supporting the patients closely, so they need to be included in the counselling as well. Practice packs given at this stage and opportunity for questions, of course. So I think it's important to reiterate, as I said before, the importance of using the practice pack at home. Some patients will be very reluctant to do this, and I think it's important to say that they're not. It's going to really help their recovery to use the practice pack. That will improve in confidence. They'll know better what to expect and what questions they have to ask. We offer them peer support if time allows before their operation, and of course with our cancer surgery sometimes that window of time can be very short, but if it's indicated by patient need as well, some people don't feel that it's going to help them to talk to somebody who have had a stoma, but some people do, so I think it's important to offer that to the patients. We do have clinical psychology support available for patients with extreme need. At present, of course, that's case by case and as time allows. Not all patients, in fact, very few patients will need clinical psychology, but certainly we are able to refer in to our clinical psychologist who will work with all members of the multidisciplinary team in order to support the patient going into their operation. Daily teaching and support by the stoma team. Present in our service and probably in lots of services. We don't have a weekend specialist service, but on our colorectal ward, all of our nursing team and our health care support workers are trained in stoma teaching. So they're the ones that do the weekend teaching with patients. And it's important to do that on a daily basis. If sometimes intensive teaching, like twice a day, might be necessary for patients as well to facilitate their recovery. And daily visit and support by an enhanced recovery nurse, again, in order to focus all aspects of post-op recovery and keep the patient focused on everything that they need to achieve before they go home. And that includes psychological support from enhanced recovery nurses as well. And post-operative referral to community stoma nurse for home visits. So obviously the patients are then supported at home psychologically and physically by a specialist stoma nurse. And we do post-discharge phone calls as well from the enhanced recovery team, as we talked about before. So that is a very thorough assessment in which we assess every system, patients' wounds, their bowel function. We also ask them how they're doing, importantly, how they're feeling. So we can pick up any issues at this stage and support them in their needs and their relatives as well. We often the patients put their phone on speaker so we can talk to everybody and answer any questions that they need answered. So a couple of things that patients have told us of their experience of the enhanced recovery pathway. One person said, "I don't even feel like I've had surgery." Someone else has said, "You provide a terrific service and you're making a bad situation a lot better." Nobody wants an operation, so the more we can support patients psychologically and make them feel that they have somewhere to go, they have people to ask, then that is vital for a good recovery after surgery. So in summary then, psychological support is integral in an enhanced recovery pathway and is essential to a successful recovery. We all need to manage patients' expectations. All members of the team should be saying the same thing in order to maintain patient confidence and focus them on their recovery. Patients should have robust daily support and it should be individualised to them. Not everybody will have the same needs and we need to respect that. We need to involve relatives in all discussions about expectations, as they're the main support for our patients and they can influence how the patient feels about their own recovery. They can be helpful and if they're not supported as well, they can actually hold patients back sometimes in recovery. Patients should have robust post-discharge phone support and phone numbers that they can use if they have issues or concerns. They should know really what post-operative complications can occur after discharge and who to contact and what to do. This basically empowers our patients to be partners in their own recovery. And it's important to realise as well with enhanced recovery that one size doesn't fit all. Not all hospitals will feel that they need to or have the resources to implement every ERAS intervention. Whatever is introduced in services, it needs to be driven by the data. So it's important to know what your service needs. And that's everything today. And are there any questions? Thank you for listening.
Hi, Deirdre.
Hi, Marie.
Hi, listen, thank you so much for your presentation. It was so informative, and certainly there's no doubt it really helps us walk through that journey that patients obviously patients now go through in relation to the whole enhanced recovery pathway. So just a couple of questions that on the back of your presentation. You talked about the use of practice packs preoperatively, and I guess I just wanted to explore with you the importance of introducing practice packs and what they are within the UK. What exactly does that mean, and what's your thoughts on ensuring that these are actually used preoperatively?
Yeah, sure. Well, our patients are met at a face-to-face meeting with our stoma nurses before their operation, and they are given all the information about their surgery. And as part of that, with their literature, they're given a practice pack, which is a little stoma bag and a little plastic fake stoma that they can attach to their tummy and place the bag over. They can put a bit of water in the bag, and they're advised really that it's best to start using this as soon as possible, so they can feel and see what it's really like to have a stoma. Well, not what it's really like, but it gives them an idea of how to use the pouch, what it feels like to have one in their clothing and things like that. So our patients are really recommended to use a practice pack as soon as possible. I think we find in practice that the majority don't use the practice pack, and I guess that's one of our biggest challenges, is how we encourage patients to use that preoperatively. Certainly our stoma team and ourselves have noticed the patients that do use it.
Yeah.
Because they're more confident, they're more prepared psychologically, and they know what to expect from their stoma teaching, because they have literally their muscle memory, their hands have actually done the actions. They kind of know what it feels like under their clothing, so they know what to expect. So I guess that is one of our biggest challenges, is how do we make sure patients use practice packs.
Yeah. And in an ideal world, how much would you like a patient to come to grips with the practice pack? So for example, would it be 2-3 weeks pre-operation, or what's your thoughts on that?
I genuinely think so. In my opinion, obviously, I don't have kind of our own data to back anything up, but in my opinion, I think it's vitally important for the patients at that stage to be using it every day, because that's what will happen in life after the operation, and they need to be encouraged to know that it will actually help them and support them to do this for themselves. And I guess that ties in with encouraging the patient to be their own director of their own recovery and take responsibility for their own recovery. And it's our responsibility, I think, to emphasize that to the patient, because we can tell them, look, we know patients are more confident, they feel more supported if they have done this before their operation, so we think you should do this too, and how can we help you?
Yeah, absolutely. Yeah. And you'd also talked about barriers to implementation, within the whole enhanced recovery pathway. And in your opinion, what are the main barriers that you come up against?
Well, I think it's really difficult to get the whole team working together. I think that's really the main barrier, to not just for stoma care, but for implementation for enhanced recovery altogether. So it's really making sure that every person in the team has buy-in for the enhanced recovery program and is saying the same things to patients. So I'd say one of the main barriers is if we're not all saying the same things to patients, they're going to pick up on that immediately. So they're not going to have confidence in the whole team, and they're maybe not going to, if, for example, the stoma nurse says you must use the practice pack and the enhanced recovery nurse doesn't even mention the practice pack, or vice versa. The patient's not going to think that that's actually an important part of their recovery, a very important part of their recovery. So we all need to be singing from the same hymn sheet in that sense, and that includes the patient. The patient is the centre of the team. They need to feel that they're part of the team. They're not just an object that we're kind of operating on. It's up to them to kind of work with us and work with themselves as well. So I'd say that's one of the main barriers. And also that we don't have enough time sometimes before colorectal surgery. So we only have time maybe to see them once, but are there other things that we can do to have more contact with the patient before surgery rather than just one appointment? So I'd say that's a barrier as well.
Yeah. I mean, obviously, I've heard a lot of feedback now in relation to patients who've gone through a proper enhanced recovery program, and all the modalities have been introduced, and clearly, surgically, physically, they've done so much better than the historical sort of pathway. But for me, as a stoma care nurse, the concern is that if a patient is discharged now on, for example, day 3, day 4 post-surgery, because physically they're doing so well.
Yeah.
It for me, it's, what happens with that whole psychological recovery and support that historically stoma care nurses would have been able to address in the hospital setting.
Yeah.
And guess for me, it's, how are you aware of how this is now being addressed?
I guess a major part for me, a major part of the enhanced recovery service is post-discharge. So in order to facilitate early discharge, we, as an enhanced recovery team, follow patients up at home very quickly after they're discharged, which wasn't part of wasn't part of the surgical service prior to kind of enhanced recovery. Patients were just sent home, and the stoma nurses followed them up, but nobody else did. So as enhanced recovery nurses, we ideally like to ring patients the day after they go home, 1 or 2 days after they go home, see how they're getting on, and we use a very systemic assessment when we're talking to those patients. It's not just a quick phone call, hi, how are you, how's it going, as part of it is bowel function, and for stoma patients as well, is how are they coping. Obviously our first question to the patient is, how are you feeling, so we've got to know that patient during their admission, and they know we're going to contact them, they know they've got us as a support as well as the stoma team. So they have community stoma support, and they have us as well to contact. So not only do we follow them up with several phone calls as needed, we give them our contact number as well. And because we've built up that relationship, they feel very comfortable actually telephoning us if they've got any issues or problems, and quite often we're asked basic stoma issues as well that we can then, if we can't answer them ourselves, being experienced colorectal nurses, we can back to the stoma team, and we can contact the stoma team and say, this patient's struggling a bit, can you give them a wee call, which doesn't happen often because they do have good community support from the stoma team. But there's that extra support because that patient's going home a lot sooner than they would otherwise have done, and we find that's really helpful for patients.
Okay, well, Deirdre, thank you so much once again for your insight. It's been fabulous. Thank you.
You're welcome. Thank you.